won't be knowing me, I'm Shamsanisa Sadia, and I'm heading Unit 2 of Al Nafis Medical College and Hospital, the Ops Gynae Department, which is the Islamabad campus of ISRA University. So ISRA University is the main campus is there in Hyderabad, and they also have two campuses each in Karachi and Islamabad. So I'm here at Islamabad campus. So we're going to talk about PROM and PPROM today. So we're going to start with what actually does PROM, the abbreviation PROM stand for, and what does PPROM stand for. So PROM is actually pre-labor rupture of membranes. So this is the correct terminology. Previously, premature rupture of membranes was also used, was supposed to be the abbreviation of PROM. So premature rupture of membranes means when do rupture of membranes normally occur? They normally occur once the spontaneous onset of labor has occurred, spontaneous or induced or stimulated, whatever. When the labor has started or the onset of labor has been established, only then rupture of membranes generally occur. If the rupture of membranes occur prior to this incidence, prior to the onset of labor, then it is premature or pre-labor rupture of membranes. And if it occurs prior to 37 weeks, then it is PPROM, that is preterm pre-labor rupture of membranes. So I've seen many students, many candidates confusing premature rupture of membranes with preterm pre-labor rupture of membranes. So premature rupture of membranes is actually pre-labor rupture of membranes. So the correct terminology, which is currently emphasized upon, is pre-labor rupture of membranes and preterm pre-labor of membranes. So we should be using the correct terminology. So in the next about an hour, we're going to define PROM and PPROM, describe the risk factors and the causative factors which lead to these conditions, and discuss the management options along with the complications associated with PROM and PPROM. And we'll briefly go through the preventive measures as well. So pre-labor rupture of membranes is the correct terminology, which was previously called premature rupture of membranes. It is the rupture of membranes in the absence of uterine activity, that is prior to the onset of labor. And this, when it occurs at term, it is PROM, pre-labor rupture of membranes, and once it occurs prior to 37 weeks, but of course after 24 weeks, which is the age of viability, it is preterm pre-labor rupture of membranes, or PPROM. So PROM occurs in about 8% of term pregnancies. However, although PPROM complicates only 2% of pregnancies, but it is associated with 40% of preterm deliveries. So you can imagine what a load on maternity and neonatal services is going to be because of PPROM. Following rupture of membranes, whenever rupture of membranes occurs, it is ultimately followed by spontaneous onset of labor. The latency period between the rupture of membranes and the spontaneous onset of labor is inversely proportional to the gestational age. That means the greater the gestational age, the shorter will be the latency period. So if the membranes rupture nearer to term, labor will start sooner. And less the gestational age, more the latency period, and more the associated risks as well. In term PROM, about 80% of women will go into spontaneous labor within 12 hours, and in 24 hours, about 95% of women will 95% of women will go into labor. However, PPROM, when that occurs, 50% of women will go into labor within a week. So the mean latency period is 50%. However, 75% will go into labor spontaneously within 2 weeks. So why are we so worried about the rupture of membranes? When membranes rupture, amniotic fluid drains out of the amniotic cavity. So what is the function of amniotic membrane? Well, amniotic membrane actually is essentially a barrier to infection, and it maintains the amniotic fluid inside the amniotic cavity, as well as it is a storage site for substrates, some essential substrates. So amniotic membrane is important for the fetus as well as the prevention of infection to mother as well. The presence of adequate amount of amniotic fluid not only helps in the development, appropriate development or adequate development of pulmonary system, it also by allowing full fetal movements allows the development of the musculoskeletal system as well. Additionally, it protects the fetus and the cord from compression and trauma, which might occur because of impact on the maternal abdomen. And it also maintains a relatively constant temperature, preventing heat loss from the baby, from the fetus. So what happens following PROM, which is pre-labor rupture of membranes, whether it occurs at term or preterm? One thing that needs to be kept in mind when we talk about the management and we talk about the complications which are associated with this condition is that the postnatal survival of the baby is directly related to the birth weight and the gestational age at delivery. Most of the complications are associated with the preterm delivery and the infectious morbidity, which might be associated with PROM. So what are the risks as term? These are basically the infectious morbidity which is associated with PROM. So at term, for the fetus, there might be ascending infection, which could be chorioamnionitis and phaeocytis. What is phaeocytis? It is the infection of the fetal membranes as well as the umbilical cord. Maternal infection might occur because of the chorioamnionitis. It might seep through into the uterine structure and leading to uterine infection and typically postpartum endometritis. The risks associated with term are basically of infection, the associated infection. But when PPROM occurs, there is significant neonatal morbidity and mortality, which is not only associated with the infectious morbidity, which is chorioamnionitis and sepsis, which is linked to phaeocytis, cerebral palsy. As a result of chorioamnionitis, there could be cerebral palsy, there could be lung disease, pneumonia, RDS, and all that. In addition to that, all the complications associated with preterm delivery are there as well. Now, abruption can be a consequence of PPROM, and it could be a cause of PPROM as well. Once, if there is like polyhydramnias or multiple gestation, in that particular case, when PPROM occurs, there could be cord prolapse, and because of oligohydramnias or reduced liquor volume, there could be compression of the cord as well. So cord complications are increased. Pulmonary hyperplasia and limb deformities occur if PPROM is occurring at the extreme of the age of viability, that is nearer to 24 weeks. So when that occurs, pulmonary hyperplasia occurs in 10% of cases if the rupture of membrane is at less than 25 weeks. So pulmonary hyperplasia has long-standing complications for the baby, which might as well lead to severe maternal morbidity as well as mortality. Limb deformities occur because of the reduced liquor around the baby, which restricts the baby's movements, leading to formation of flexion contractures and talipes as well. But these things occur when there is reduced liquor at extreme of gestation, right? Or when rupture of membranes occur in the pre-viable age, in the second trimester. So what are the maternal complications that might be associated with PPROM? There could be increased incidence of operative delivery because of increased incidence of fetal heart abnormalities. There can be endometritis and puerperal sepsis. And then because of the endometritis, there could be retained placenta and postpartum hemorrhage. There is an increased risk of postpartum hemorrhage as well. And we know whenever there is sepsis, there could be thromboembolic complications as well. So whole of this lecture has been made by compiling the information which has been taken from the RCOG guideline and Dewhurst, and then EBM, strategy, 10 teachers. So I've compiled all the information that was spread out in these books into into this one lecture, right? So it is sort of a notes for you which you can readily refer to while revising this subject, right? So what are the risk factors for PROM? I'm sure all of you know that. The most important of the risk factor for PROM is a history of PROM in previous pregnancy, along with genitourinary infections. So these are the two most important risk factors for pre-labor rupture of membranes. As I talked about it earlier on as well, that antepartum hemorrhage could not only be a consequence of PROM, it can also be a cause of PROM. So 3 to 5% of PROM might as well be associated with antepartum hemorrhage. Smoking is another very important risk factor, and it is dose dependent. The increased incidence of smoking, if the mother is smoking, the dose of smoking is more for a mother relative to another, then there is an increased risk for PROM. Iatrogenic causes are ECV and amniocentesis, and this is the reason why ECV is recommended preferably at term. Uterine overdistension due to multiple pregnancy of polyhydramnios lead to PROM as well. So how do we diagnose it? So this needs to be emphasized, that the clinical diagnosis, the clinical evaluation, and the clinical assessment of PROM is the mainstay of diagnosis. So the maternal history of a gush of fluid followed by recurrent dampness will correctly identify more than 90% of the cases. So typically our patients say that there was a gush of fluid up to the feet कि पानी पड़ गया या जैसे पेशाब निकल गया और वो नीचे टांगों तक चला गया या जहाँ पे वो बैठी हुई थी या लेटी हुई थी तो लिनन जो है वो सॉइल हो गई या चेयर जो थी वो सॉइल हो गई. So this is the typical characteristic history which uh, which if the patient is not giving you correctly, then you need to ask leading questions to clarify it, right? Sterile speculum examination is suggested, and many of the experts suggest that it is preferable that the patient should lie down in lateral position or dorsal position for at least 20 to 30 minutes prior to a sterile speculum examination. And there would be, when you insert the speculum, and it is usually the cuscus speculum which is inserted in the dorsal position, so it will you will identify the pooling of liquor in the posterior fornix, or you can even see it coming right out of the cervix. And if you are not able to identify this, sometimes a gentle fundal pressure will make this make the liquor come out, and you can further see it, confirm it. So whenever you see liquor pooling in the posterior fornix or coming out of the cervix, you need to note the color of the liquor, whether it is clear or not. If there is meconium there, so in cases of PPROM, presence of meconium is suggestive of intra um, of is indicative of chorioamnionitis actually. So intrauterine infection is indicated if there is meconium. And if meconium is identified at the time of PROM, which is occurring at term, this might be an indication to go for induction of labor straight away, or stimulation of labor straight away. While you have inserted the speculum, you can very well see the cervix as well, and the length and dilatation of the cervix needs to be assessed as well. So this is extremely important, that whenever you are suspecting PROM, pre-labor rupture of membranes, there is no established labor, there is no indication of established labor. In that particular case, digital vaginal examination must not be done. Why? Because it is known to increase the incidence of chorioamnionitis, postpartum endometritis, and neonatal infection. So it is extremely important. Until and unless the patient has palpable uterine contractions, you do not do a digital vaginal examination. Only do a sterile speculum examination following complete SOPs of and for maintaining by maintaining aseptic measures. So the diagnosis obviously is through history and speculum examination. But if speculum examination does not demonstrate amniotic fluid, which might occur in 10 to 20% of the cases, then certain bedside testing on vaginal fluid can be considered. So the current recommendation is for placental alpha microglobulin 1, which is PAMG1, Amnisure. It has a very high sensitivity, about 95%, and specificity of more than 98%, 99%, up to 99%. So it's very effective. The other test is actin PROM test, which is insulin-like growth factor binding protein 1. So what is done is, like, you take a sample of the amniotic fluid, just the way you take a high vaginal swab, and insert it into the given bottle, which has which identifies the placental alpha microglobulin 1, which are more in the amniotic fluid relative to the cervical secretions and the vaginal secretions or even the semen. The role of ultrasound assessment of amniotic fluid volume for the diagnosis of PROM and PPROM is not very clear. As amniotic fluid volume, we all know, varies a lot in amount at term, and more so during the preterm period. Somewhere between 600 ml to 1200 ml is normal variation. However, if there is oligohydramnios, this might support your diagnosis, but it cannot confirm your diagnosis. Another thing is that if the amniotic fluid volume or the deep vertical pocket is less than 2 centimeter, and you know that you have already confirmed PROM or PPROM, then we should be anticipating that the latency period is not going to be longer than 7 days. Previously, nitrazine tests and Ferning tests were performed. What is nitrazine test? It is the testing of pH of the vaginal fluid. The normal pH is between 3.8 to 4.5. But if the pH is increased, it is alkaline, then it was suspected that it was alkaline because of the presence of amniotic fluid. But there are so many other confounding factors, such as vaginal infection, cervicitis, presence of blood, even presence of semen, which can confound your finding. So it is no more recommended. Nitrazine test is no more recommended. Ferning test again was that when amniotic fluid is spread, the secretions are spread over a glass slide, and if amniotic fluid is present, it is tried and it is looked at under the microscope, then the Ferning pattern is observed. That was called the Ferning test. Currently, through research trials, pads are being available now which change color if the fluid which soaks the pad, the pH is more than 5.2. So these things are coming, let's see. But currently the recommendation is for placental alpha microglobulin 1 and insulin-like growth factor binding protein 1, both by RCOG and NICE. So what is a differential diagnosis? A patient comes to you and says that she has complaint of watery vaginal discharge. This is the typical complaint: gush of fluid, watery vaginal discharge. So if she says there is vaginal discharge, you need to have a list of differential diagnosis and then explore the history to come to a provisional diagnosis. So urinary stress incontinence is very common in pregnancy, and that needs to be excluded. Excessive vaginal or cervical secretions could be there physiologically as well as pathologically, and that needs to be explored through history and through examination as well. So the mainstay of management is to balance the risk of prematurity versus the risk of maternal and fetal infection. So the risk of prematurity is if the delivery is encouraged right away, whenever PROM occurs. And the risk of maternal and fetal infection is there if the delivery is delayed. So RCOG and NICE recommend that for patients who are more than 37 weeks of, at more than 37 weeks of gestation, labor should be stimulated in that. And that group of women who present with PPROM less than 34 weeks, if there is no contraindication to continuing pregnancy, and what is a contraindication to continuing pregnancy? Any evidence of chorioamnionitis, any fetal-maternal condition, fetal compromise, maternal evidence of, or maternal, any other maternal indications such as severe preeclampsia, which might have led to antepartum hemorrhage, which might have presented as PPROM. In such cases, if there is no contraindication to continuing or prolonging pregnancy up to term, and expectant management should be followed. For those patients, that group of patients which are between 34 and 37 weeks, the decision of stimulation of labor needs to be individualized. Again, depending upon the evidence or the risk of infectious morbidity, both for the baby and the mother, for the presence of additional comorbidities. So that will guide our decision regarding expectant management or regarding continuing the pregnancy till 37 weeks. Women with PROM at term should be offered a choice of stimulation of labor or expectant management. However, induction of labor is recommended after uh, after waiting for about 24 hours following pre-labor rupture of membranes. As we had discussed earlier on, so while counseling patient, we need to tell them that if we wait for 24 hours, the chances are that you might as well go into labor, that there is 95% chance that you'll go into spontaneous labor. Even after 12 hours, 80% of the women will go into spontaneous labor. So with discussion and respecting the patient desire, we need to proceed with our management in PROM at term, recommending stimulation of labor over expectant management. So what are the risks and benefits of induction of labor for PROM at term? There were 12 trials carried out over 7,000 women, and all of them indicated that there was reduced risk of chorioamnionitis if induction of labor was done instead of expectant management once the patient was at 37 weeks. And the number needed to treat was 50 for chorioamnionitis. And the risk of endometritis is also decreased. Fewer neonatal unit admissions. There wasn't any increased risk of cesarean section of operative vaginal delivery if stimulation was done instead of waiting. This is the only reason that the patients want to wait, that they want, they fear that interventions or like cesarean section or forceps or vacuum will be increased if induction of labor is carried out. So evidence has proved that there is no increased risk of cesarean section or operative vaginal delivery. Maternal satisfaction rates are higher with induction of labor than with expectant management. And however, there is a slight increased risk of lower birth weight. Fetal or perinatal mortality was less in the induction of labor group relative to the expectant group, the group of patients who were managed expectantly in which fetal or perinatal mortality was 7. No maternal mortality in either groups was observed in these trials where 7,000 women were observed for the two management options. So we have decided with the evidence, the recommendation is that after 37 weeks, if PROM occurs, there is no justification for expectant management. By giving or observing for a latency period of 24 hours maximum, the patient needs to be stimulated. However, those patients in whom there is preterm, pre-labor rupture of membranes after 24 weeks, but who are less than 37 weeks, in them, if there is no contraindication to continuing pregnancy, then expectant management should be offered. So when expectant management is offered, what do we need to do? One thing is foremost, tocolysis is contraindicated. if during expectant management at any time, now this is something which is extremely important, which candidates confuse a lot. For preterm delivery, yes, you do consider tocolysis, but for preterm labor, you do consider tocolysis, but there is no place of tocolysis once membranes have ruptured. Once membranes have ruptured, if there is spontaneous onset of labor, this might as well be because of subclinical chorioamnionitis, right? So when there is chorioamnionitis, stopping labor is going to be extremely drastic, will have extremely drastic effects on both the mother as well as the baby, right? So tocolysis is not to be carried out. There is no place for tocolysis in expectant management while carrying out expectant management for PPROM. Routinely, we take high vaginal swabs in patients who have rupture of membranes prior to labor. And although these cultures, they do not correlate well with the risk of chorioamnionitis, however, by identifying the causative organisms, we can sort of modify our antibiotic therapy, both for the mother as well as the preterm neonate. And if group B streptococcus is identified, then that might be an indication for induction of labor. Hospital versus outpatient management. One thing is clear, that for the initial 48 to 72 hours after rupture of membranes, the patient needs to have hospital-based care, because this is a time which is the most high risk for complications to occur, for if there is PPROM, then for preterm labor to set in, or in cases of PROM at term, infectious morbidity to manifest itself. So the initial 48 to 72 hours, the patient needs to be in the hospital. And generally, in our patients, they need to be monitored in the hospital. Outpatient management has to be based only for those patients who can easily report back to the hospital, who are wise enough and intelligent enough to observe for the symptoms of infectious morbidity in them, in their own selves, and they're able to monitor themselves as well, and they're able to visit the hospital at least twice weekly. So outpatient management is to be very cautiously advised. Amnioinfusion is currently not recommended as part of routine clinical practice. In fact, it is only carried out for research purposes at the moment. So once a diagnosis of PPROM has been made, we need to start the patient on antibiotics, and the current recommendation is for erythromycin, which should be given 6 hourly for 10 days, or until the woman is in established labor, whichever is sooner. So if the patient does not go into spontaneous labor within 10 days, so just a moment, I'm sorry. So if the patient does not go into labor within 10 days, then after completing a 10 days course, we need to stop the antibiotic treatment. However, In the meanwhile, if the patient goes into labor, then obviously erythromycin or the antibiotic that you're giving needs to be stopped once the patient has delivered. If PPROM occurs between 24 and 34 weeks of gestation, then it is we need to offer maternal steroids, corticosteroids for fetal lung maturity, and consider it if she is less than 36 weeks. So 24 to less than 36 weeks, during this period, if there is rupture of membranes prior to the onset of labor, we need to give steroids. Depending on the gestation, if the facility where the patient has presented cannot support neonatal resuscitative measures, appropriate facilities for neonatal resuscitation, then the patient needs to be preferably transferred in utero to a better facility where better and appropriate neonatal resuscitative uh, equipment is available. The Oracle study and the following meta-analysis provided evidence that the prophylactic use of erythromycin improves neonatal morbidity, reduces the risk of sepsis, and so it is actually improving neonatal morbidity by reducing the risk of sepsis as well as prolonging the latency period. Now, what is latency period? As we discussed earlier on, latency period is the time duration starting from the rupture of membranes to the onset of spontaneous labor. So longer it is, nearer we will be to term. So the use of erythromycin is going to improve neonatal morbidity. However, previously, when we were younger and we were postgraduate students, we used to give augmentin. But evidence proved that the use of augmentin in such patients, that is co-omaxiclave, increases the risk of necrotizing enterocolitis, and hence it should be avoided. Antibiotics of any type, when given prophylactically, do not reduce the incidence of perinatal death and neonatal encephalopathy. Neither do they affect the rates of maternal sepsis or maternal death, but they do improve longer latency period and the risk of sepsis. Why is erythromycin preferred over other antibiotics? Because it can be administered orally and it is effective against gram-positive organisms such as group B streptococcus, streptococcal and staphylococcal infections, as well as the anaerobic organisms such as mycoplasma, all of which may be implicated in chorioamnionitis. So what is required antenatally to identify infection? So while carrying out expectant management, this is pivotal. How do we identify infection in the antenatal period while we are considering or while we are practicing expectant management for the patient? Because that is the point where we will make the decision of delivering the baby. So a combination of clinical assessment as well as testing and fetal heart monitoring is important. Clinically, we need to watch for the symptoms of chorioamnionitis, infectious morbidity, monitor the temperature, the pulse, the respiratory rate, the blood pressure, and observe the uterus for uterine tenderness. And this is what we do actually. जब भी हमारी पेशेंट्स को PPROM होता है, ये हम चार्टिंग स्टार्ट कर देते हैं. और जो maternal early warning scores के charts होते हैं, preferably उन पे ये charting करनी चाहिए. Addition to that, fetal heart rate is also a very sensitive clinical tool which might as well, fetal tachycardia will indicate the some subclinical chorioamnionitis as well. Maternal blood tests that we need to carry out are C-reactive protein and white cell count. However, they're not very specific. They might be raised in so many other instances. White cell count can be normal at times in chorioamnionitis as well, even low when there is sepsis. White cell count can normally be raised, physiologically be raised during pregnancy. And those patients who are given corticosteroids, in them, white cell count might be raised for about 72 hours to 5 days as well. So not very helpful, but it is actually the trend. The serial testing is important. Same with C-reactive protein. The serial rise in C-reactive protein can be an indication, and it is the holistic picture. Nothing in isolation has to be considered. In fact, the whole of the picture, the holistic picture of clinical assessment, fetal assessment, as well as blood testing, that will indicate that the patient might be suffering from subclinical chorioamnionitis, which might manifest clinically then. C-reactive proteins, uh, a rise in them, or very high levels, more than 50 or more than 40 might be indicative without any other focus of infection such as pyelonephritis, pneumonia, DVT, or anything else that might lead to a C-reactive protein. Without any other focus of infection, if C-reactive proteins are very high, then a single reading might as well be indicative of chorioamnionitis, and thus it will have an impact on our management, and we will reconsider or revisit our decision of expectant management. So what are the symptoms of clinical chorioamnionitis? Women should be counseled regarding them. They should observe it themselves, and we need to observe the women for it. If she complains on history, if she complains of lower abdominal pain, malaise, or reduced fetal movement, that's very important. And then if fever is there, there is abnormal vaginal discharge or absence of fetal breathing movements on ultrasound, all of them will indicate clinical chorioamnionitis. For research purposes, although chorioamnionitis is very difficult to diagnose, but for research purposes, maternal pyrexia of more than 38 degrees centigrade with at least two of the following, which is maternal tachycardia, fetal tachycardia, uterine tenderness, raised C-reactive protein with a rapid rise or a single very high value. We just talked about it, in the absence of any other focus of infection or offensive vaginal discharge. Any two of them, along with maternal pyrexia, is definitely chorioamnionitis. Any patient who has PPROM, she needs to be counseled by a neonatologist as well. A meeting should be arranged, and in anticipation of the delivery, they need to have a talk with the neonatologist, and that is going to have a good effect on the mental health of the parents, because women with PPROM and their partners need additional emotional support during pregnancy as well as postnatally, because it has been proved through evidence that they have post-traumatic stress disorders in them. Magnesium sulfate need to be given in those patients who are less than 34 weeks and who have PPROM, and you're anticipating delivery within 24 hours. So there is PPROM, and then now you anticipate that they have started off with the onset of labor, spontaneous onset of labor, or there is any other indication such as chorioamnionitis, meconium, antepartum hemorrhage, or any other indication for which you have decided that is going to be a planned preterm birth. within 24 hours. In such patients who are less than 34 weeks, we need to give intravenous magnesium sulfate for neuroprotection. Now, this is very important. बहुत सारे कैंडिडेट्स कंफ्यूज कर जाते हैं प्रॉम प्री टर्म प्रॉम जो कि 24 वीक से ज़्यादा है and preterm PROM in the pre-viable age, less than 24 weeks. When there is rupture of membranes at less than 24 weeks, most of the times we will be considering termination of pregnancy. Why? Because there is a significant risk of lethal pulmonary hypoplasia, which cannot be predicted on prenatal ultrasound. There can be chronic, even if there is not lethal pulmonary hyperplasia, there will be chronic pulmonary morbidity, definitely. There will be fetal limb contractures. And there is an increased incidence of extreme preterm birth with the consequent coexistent morbidity and mortality such as cerebral palsy and so on and so forth. Hence, if there is rupture of membranes prior to 24 weeks of gestation, such patient needs to be counseled regarding termination of pregnancy and the risks associated with continuing the pregnancy. How can we prevent PPROM? Obviously, history is very important. So past history needs to be taken in every patient, and those patients who might be at risk of PPROM need to be identified as a high risk group. Whenever there is genitourinary infection, that is one of the very, very important risk factor, and that needs to be identified earlier on, asymptomatic bacteriuria as well, and they need to be appropriately treated. If the patient is a smoker, then smoking should be, she should be encouraged to stop smoking, and wherever there is an indication regarding cervical cerclage, then in cases of cervical incompetence, then cervical cerclage needs to be applied. So those patients with second trimester loss, late second trimester losses, or PPROM or preterm birth previously, along with cervical shortening, they can be they can be advised to go for cervical cerclage. So any questions? I think we have about 7 minutes. So if there is any question, I'm happy to take them. So if there is no question, then we'll wrap it up. So in summary, we talked about PROM and PPROM today and their definitions, and why do we need to differentiate between the two? Because their managements are different, right? And then we moved on to the risk factors. So breach with PPROM, is that a question? So
Assalamu
breach,
alaikum, ma'am.
G. Walaikum
And
assalam.
I wanted to ask a question that if we start with there is a pre-prom and we start with tablet erythrocin, and as you said that we can give it for 10 days or wait till the within 10 days if the patient goes in labor. Say if the patient do not go in labor and we have to wait till 37 weeks, that every other all other things are normal. So after 10 days we'll stop with erythrocin and we'll
Yes,
just
after
observe the
10 days,
patient.
we will stop erythromycin. 10 days antibiotic therapy is good enough. So after 10 days, we need to stop.
Okay.
Any other question? Neuroprotection. So we talked about magnesium sulfate for any preterm birth, whether spontaneous or planned, whenever preterm birth is anticipated within 24 hours prior to 34 weeks of gestation, we will consider 30 weeks से कम में तो we will recommend, we will offer magnesium sulfate. लेकिन 34 weeks से कम में we need to consider magnesium sulfate for neuroprotection to prevent cerebral palsy. It has been proved through evidence that when magnesium sulfate is given to IV dose of magnesium sulfate is given to the patients who might be delivering within 24 hours, but who are less than 34 weeks, we need to give them magnesium sulfate for neuroprotection.
Ma'am, the duration of administration of the bolus of Maxelf, ma'am. The duration of administration of bolus. Duration. Ma'am, we are administering the bolus dose, ma'am.
Currently, neuroprotection के लिए जो dose है वो 4 gram IV है over 5 minutes. It should not be less than 3 minutes, but over 5 minutes, 4 grams magnesium sulfate जो है वो 20% weight by volume solution जो हम बनाते हैं कि हम 8 ml लेते हैं 4 grams magnesium sulfate और 12 ml लेते हैं normal saline. तो इस तरह से 20 ml की जो हमारे पास solution तैयार होता है वो 20% weight by volume होता है, वो over 5 minutes जो है वो दिया जाता है. Start dose दी जाती है for neuroprotection.
Thank you, ma'am.
For the baby's neuroprotection.
मैम इसके लिए मेंटेनेंस डोज नहीं देनी होती, जैसे कि 24 आवर्स के लिए फर्दर मेंटेनेंस देनी होगी?
मुझे आवाज नहीं आ रही, आपकी क्लियर आवाज नहीं आ रही, प्लीज रिपीट करें.
मैग्नीशियम सल्फेट की बोलस डोज देने के बाद मेंटेनेंस देने की जरूरत नहीं है क्या?
मैग्नीशियम सल्फेट की
आईवी बोलस डोज देने के बाद मेंटेनेंस डोज देने की नीड है?
अच्छा देखिए, इस पे बहुत ज़्यादा अभी मतलब कि ट्रायल्स हो रहे हैं और उसमें न्यूरो प्रोटेक्शन के लिए मैग्नीशियम सल्फेट की बोलस डोज के बाद 1 ग्राम पर आवर के लिहाज से मेंटेनेंस डोज भी कंसिडर की गई पेशेंट्स में. और एक अनदर ग्रुप को उन्होंने कंपेयर किया कि 4 ग्राम स्टार्ट दे के विद इन 24 आवर्स बेबी की न्यूरो प्रोटेक्शन के लिए, तो बहुत ज़्यादा डिफरेंसेस नहीं आए. तो अभी मतलब कि दोनों चीज़ें की जा सकती हैं लेकिन बहुत ज़्यादा डिफरेंस नहीं है. तो जनरली बहुत सारे लोग जो हैं वो स्टार्ट डोज ही दे रहे होते हैं. So chorioamnionitis, there is a question, is chorioamnionitis an indication for cesarean section? No, chorioamnionitis is not an indication for cesarean section until and unless there is a pathological CTG. However, we will aim for vaginal delivery, but the risk of cesarean section obviously increases when chorioamnionitis sets in. Why? Because there is an increased incidence of fetal heart rate abnormalities once there is chorioamnionitis. So we need to keep the patient prepared for cesarean section, and we need to be prepared and beware of postpartum hemorrhage as well in such patients. But chorioamnionitis per se is not an indication for cesarean section until and unless there are fetal heart abnormalities which justify a cesarean section. So I think we're done with the questions as well. And if there are no more questions, the time is up as well. And let's see, I wish you best of luck, all of you. and I'll be happy with any questions that might be forwarded towards me, and I'm happy to take them and clarify your queries. So thank you very much. I'll take leave now. Allah
Thank you
Hafiz.
so much, Dr. Shamsunisa, for this wonderful session. I would like to add few points about the course.
Ji, please go ahead.
Assalamu alaikum everyone. This is Asma Amjad from the backend team of Mad Exam Expert. I'm here to guide you more about the course. Basically, we have started our FCPS Part 2 Obs and Gynae regular course. The starting date of this course is 20th May 2021, and the duration of this course will be 3 months. The mentors of this course will be Dr. Sumaira Ijaz and Dr. Amna Najam. In this course, there will be MCQ bank. After every live session, there will be MCQs that you can solve them for your preparation. There will be course library. There will be 2 live sessions every week. There will be active Telegram group discussions where you can directly interact with your mentor. There will be online mock exams on the CPSP pattern with the time limit so that you will be well prepared before your exams. So if you want to register for this course, what you have to do, you have to contact on this WhatsApp number so that our backend team can register you. Thank you so much for your time.
So all the best, all of you. And I highly recommend the course with the plan that I've just seen, the way they have planned and scheduled all the sessions. I'm sure whosoever will follow it from the beginning will definitely be successful in the exam at the end of the course. So best of luck and thank you very much. Allah Hafiz.
Thank you so much, ma'am, Samshinasa. And during the course, we'll be inviting you for the lectures as well if you are available. Inshallah, हम आपको
Sure,
lectures
inshallah.
के लिए भी थोड़ा सा तंग करेंगे. ठीक है?
Assalamu alaikum,
Thank you
ma'am.
so much.
Yeah, Assalamu alaikum, ma'am. Dr. Sumaira here, ma'am.
Hello, Sumaira. Good
Welcome,
to
and
hear
yeah,
you.
I'm
Good to
yes,
hear you.
ma'am. Yeah, thank you so much. I'm so honored to have you with us on the forum, and it will be going to be a very, very good, inshallah, ta'ala, in the future for us. So thank you so much, ma'am. It was a very nice lecture. And for all the students, we are so lucky to have Professor Shamsunisa Sadia with us on board. She's an excellent teacher. I was her student, and it's an honor for me to be with her again. Thank you, ma'am.
Okay, Allah
Welcome.
Hafiz.
Okay,
Thank you.
take care. Allah Hafiz.